Thank you all for being here today. We are now starting with our next session titled Digital Health Services in Non-Communicable Diseases and Preventive Healthcare. Today's discussion will delve into the intricate dynamics of this transition, seeking to understand the main driving forces between the surge from communicable diseases to non-communicable diseases like diabetes, hypertension, and more. From lifestyle choices to environmental factors, our exploration aims to unearth these hits that will guide us in crafting resilient and adaptive frameworks in healthcare. Here we will unravel the tapestry of possibilities that digital health services can present for NCDs, that is, non-communicable diseases. From diabetes to cardiovascular, the advent of digital health services definitely offers a transformative paradigm for healthcare solutions.
Let's welcome our panelists for this session. Dr. Saurabh Gupta, Assistant Professor of Biomedical Engineering, NIT Raipur. He is a graduate in Biomedical Engineering and a PhD in the area of optical topography from Indian Institute of Science, Bangalore. We welcome you, sir. Please put your hands together for all our panelists as I call out their names. Next, we have Dr. Sabine Kapasi, Health Policy and Governance Strategist. Dr. Kapasi has extensive experience in healthcare and health tech economic welfare systems. She has served as the UN Strategy Lead on the COVID-19 Task Force. Her expertise extends to public sector financing, risk handling, health finance policy, insurance, and supply chain procurement. We welcome you, ma'am. Next, we have Dr. Sanjay Sharma, co-founder FootSecure Yostra Labs. He holds a blend of qualifications in management, artificial intelligence, and health economics. He is inventor with 6 international patents in medtech and telemedicine. He was also felicitated as the rising star in the Times Healthcare Achievers Awards. We welcome you, sir. And lastly on our panel is Dr. Surjeet Thakur, founder and CEO TrioTree Technologies. That is a fast-growing healthcare IT company. Dr. Thakur has more than 23 years of experience in healthcare technology implementation, design, and development of healthcare solutions. We welcome you, sir, and let the session begin.
Hello, thank you. So, good morning again, everybody, and I welcome you all for this panel discussion on digital services for non-communicable diseases. So, we have really got a very good insights from the last discussion where it was on One Health and how we should work on the life-centered design instead of human-centered designs. And maybe that could be one of the reason because for these non-communicable diseases prevalence in India these days, because maybe we are not looking the health holistically, the health of the life in general. To continue that, we have this panel discussion with eminent speakers. Dr. Sabina we have, who has worked with organizations like WHO, United Nations, and has a vast experience in policy making. Then we have Dr. Sanjay, who is a co-founder of FootSecure and Yostra Labs, and he's a serial entrepreneur and has mentored many startups in IIM Bangalore. And then we have Mr. Surjeet Thakur, who is the founder and CEO of TrioTree Technologies and a vast experience in US and other countries with IT and healthcare. So the problem is gross, as we have seen, the kind of pandemic that we have about these Hello. Yeah. Thank you. So yeah, we all are aware of this pandemic of these non-communicable diseases that's spreading in India, and to align it with the conference theme uh, of of validation with the emerging technologies, I will request Dr. Sabina to please throw some light on like what are the unmet needs and what are the problems to be solved when it comes to this digital health policies for the non-communicable diseases. Yeah, please.
Thanks a lot, Saurabh. I think let's start with, first of all, we all know what is NCDs now. I'm sure you all are sitting here, so we know what is NCDs. But one of the biggest problems in NCDs today is underdiagnosis. It's not that we don't know what it is, though that is also evolving and something we should keep in mind. The way NCDs used to present, the way they presented in different genders, they presented in different communities, have been known to shift and change as we go. For example, cardiovascular diseases in women present very, very differently than they do in men. That aside, the fact that we are not diagnosing NCDs early enough is one of the biggest problems. So when do any of us go to a hospital, right? When we have a problem. Most of us don't go to a hospital for a regular checkup, at least not in India. And not just in India, nowhere in the global south do we do that. And secondly, when we have a symptom, at least when it comes to an NCD, we are already, half of the battle is already lost. So we are not at a place where we can go back to maintaining homeostasis. Now we have to maintain status quo at that point. So one of the largest challenges when it comes to any digital intervention, and coming back to the theme, digital interventions today are not just about, are about teleconsultation and a couple of other consumer-based solutions, but it's about tying a lot of industries together, tying finance and health together, tying FMCG and health together, trying to build solutions which are consumable as well as extremely cost-effective that can actually be mass-scaled. Right? For example, today someone whose daily meal token, or rather cost per meal, is just 20 rupees, how can you expect them to go buy green leafy vegetables? So what do you do instead? These are the solutions that can be put together by bringing digital technology into it and aggregating different ecosystems together. So I think one of the bigger challenges that we face in NCDs is early diagnosis and implementation of preventive care. And one of the ways that digital technology really does make a difference is by trying to bring different stakeholders together in a much larger way to solve this problem. So that are my 2 cents to begin with.
So yeah, I think it's good to know that we should develop technologies which helps us in early diagnosis, effective treatment, and sustained management. Yeah, good. So Dr. Sanjay, with your vast experience in mentoring the healthcare startups in the line of for non-communicable diseases, if you can just put some light.
Sorry for the deviation. I had a presentation even though it's a panel discussion. So I'll just run through the presentation. And one of the things that we need to look at is I'm a pediatric surgeon. People would have heard about pediatric surgeons, but can we have the presentation? People would have heard about pediatric surgeons, but podiatry is very niche in India, where we look at the foot and ankle. And when we look at the foot and ankle, that's the most neglected part of our body. Particularly if somebody goes to a pedicure or something like that, that's the only time when we actually take care of our feet, but otherwise we don't take care of our feet. So being a podiatric surgeon, most of my digital inventions has been with regards to the foot, and especially in the context of the NCDs, feet gets most important in diabetes. So, for example, in India we have about 70 million diabetics, and 34 million have a diabetic peripheral neuropathy or peripheral arterial disease. This affects the feet. 6 million has a diabetic foot ulcer, And 1.3 million amputations happen every year. Globally, every 20 seconds, there is one limb amputation that happens due to diabetes. And we are not even aware of that, and there has been no awareness that is being created on that. We spend about 10.5 billion. She was talking about what the financing part of the NCDs. We spend about, in India, I'm talking, even though it's in USD, yearly in India for managing a diabetic foot ulcer. And the recent studies on the mortality rate states that a person who has undergone an amputation dies, 70% of the people who have undergone an amputation dies within the next 5 years. The mortality rate is higher than comprehensive cancers, except for the lung cancer. With this being there, in every movie theater we talk about cancer, but nobody talks about the disease of a diabetic foot condition. So the inventions that came in was, from the medtech perspective, this is NeuroTouch, which is a digital device which assesses the diabetic peripheral neuropathy, various parameters, and which can help in preventing these amputations. Podiatric interventions has said that 80% of these amputations can be prevented if there is an early awareness and an early intervention. And that is what we are looking at. We started off with this first one, with this device. Again, in the last session, they were talking about BIRAC grants and other things. This was a BIRAC grantee product that was invented in India, Make in India, Made in India perspective. And today it is globally approved, FDA approved, and being sold internationally. This is the second one that we looked at when the AI. I'm just skipping all this because I have presented these in the previous InnoHEALTH sessions also, and the one that I'm coming up is other one is an AI product. We are talking about diabetic foot ulcers, which leads to amputations. And most of the physicians in India, or when I completed my MBBS, we were not trained on how to treat a wound. We were trained in higher aspects of what to take care of appendicitis, what to do for a liver transplant or something like that. But a simple wound which I and you will have every day, we weren't trained on how to take care of for a wound. We weren't trained, or we ignored the training on biomechanics. How we walk, how we stand, those things is something that we ignored. Like as all of us ignore the feet, in our studies also we ignored the feet. And foot is the most complex organ. It has about 119 ligaments, 33 joints, and has 1/4 of the bones that are there in the body in the feet itself. And with such a complex structure, we have completely ignored it. And when it comes to the wound, the physicians do not know how to treat it. And it is mismanaged not only in India, across the globe, because we are not trained in the biomechanics of the feet. And that is when we said a wound has to be managed by a specialist. So we came up with an AI module where with just your normal phone, you can take the pictures of the wound, upload it, and the AI will recognize the wound bed, the peri-wound area, and the wound edges, and suggest the physicians in the rural areas to say what has to be done with this wound. A few of the images where we have developed the AI around it, how the area is calculated, how the wound edges are calculated. It says whether it is healthy, whether it's pale, granulation, hypergranulation, sloughy. So these things are being developed with an AI module itself. And this is the summary that we can get over the app. So these insights, the AI insights, from the first device that we have seen and the second device, what came up was an innovative solution for wound healing. It's a 3D, 4D bioprinting solution where we take the abdominal fat, about 20 ml or so, and then 3D print that and then put it onto the wound where the wound healing is faster. Usually a diabetic foot ulcer takes about 28 to 52 weeks for it to heal, and with the autologous 3D bioprinting, it can take only about 5 to 6 weeks to heal. I'll be able to a little bit forward this to show what is happening. can I forward it? Can I just play and just forward it? So this is an AI thing where we are taking the measurement of that thing. This is the abdominal fat that has been extracted. I can just forward it further. No, not this slide. That's video only. You have to forward it. Not possible. Okay, so we take the fat from the abdomen, and then after taking the picture, this tells us how much fat has to be taken according to the size of the wound, and based on this, it is taken, and this fat is 3D printed. This is the micronization of the fat tissue that we are seeing here, and this is the scaffold that is being printed. And this is the fat that is being printed. I would have loved to forward this, but something is not happening. So this is the thing, and then we are placing it on the wound, and it heals within 5 weeks instead of 22 weeks that we are seeing it. So that is some application of the digital application that we came across, and then all need not be digital and AI. We went back to the basics where some mechanical stuff can also happen. When we are talking about a diabetic foot, most important thing is offloading of the diabetic foot. Wherever the ulcer is there, that area has to be offloaded for that ulcer to heal. And if it is not offloaded, the ulcer will never heal, and that is why it becomes chronic. So when we were looking at the present offloading mechanisms, if you go to a diabetic footwear or a person who's a diabetic foot surgeon, he will scoop out an area in the footwear. Most of them do not do it. Most of them do not even know about offloading. But people who know today just scoop out that area, make a hollow structure in the footwear so that that wound is not touching the surface. But what happens then is a transfer ulcer where the peri-wound area gets the higher pressure, and that is where the next ulcer happens, and the next ulcer happens, next ulcer happens. So we looked at the threshold level of a person when he walks is about 200 kilopascals pressure is what is the threshold level, and anything beyond 200 kilopascals of pressure will damage the skin. So this is what we came up with, a self-offloading, dynamically self-offloading footwear, where it is, looking at this, it looks very simple. I don't know why people hadn't thought about it across the globe. It just snaps down. When we are walking, whenever there is a 200 kilopascals or more pressure, the mechanical version just snaps down, and then we will be able to offload that area dynamically when the patient is walking. So we did this study, we were talking about validation and other things. We did this study in about 100 patients, and we saw a huge difference on where the mechanical offloading is happening and where it is not happening, and how the self-offloading footwear has been useful. And again, for this product also, we were able to get the BIRAC grant, and for the validation purposes and commercialization purposes. So this is from few of the studies that has been done, validation studies that has been done, that you could see, where the arch has not been compressed. And this is something that I would wanted to focus on this InnoHEALTH session, because the previous ones has already been already commercialized. So what we are trying to do with all these AI in wound care and the images that is being taken by the NeuroTouch is to create a digital twin of the feet. So that's the next project that we are looking at. So we have started off with what we call it as a DPOC, a digital podiatry clinic in Bangalore, along with the collaboration with the IISc team, and where we are gathering data of large populations and to create a digital foot twin to look at how we can prevent these amputations that has been happening across the globe. probably in the last 10 minutes, there would have been at least 20 amputations that would have happened across the globe. And the mortality rate is so high. And probably in the next InnoHEALTH sessions, I should be throw some more light into how the digital podiatric kiosk is doing and what we have been able to do. Thank you very much.
So thank you, Dr. Sanjay. Like, it was wonderful devices that you are making, and maybe like it is good to concentrate on the effective treatments also. Yeah. So Mr. Surjeet, like you have a great experience, a long experience too in digital technologies for prevention. So I want to ask, like, what kind of sustainable IT technology, what kind of IT technologies we can use for sustainable management of these non-communicable diseases? If you can put some light on that.
Yeah, thanks. Thanks, Dr. Saurabh. So just to give a perspective, I come from a technology background. I'm not a doctor. I come from a technology background, did my MBA from IIT Delhi, but been in healthcare for the last 23, 24 years now. One of the things that we have to first understand that healthcare as an industry is different than others. People who are on this podium and people who are actually listening, both can be patients. That's one thing. So this industry is different than others. And if you look at the evolution of the entire healthcare, what Dr. Sabine also spoke about, so it was episodic care earlier. Now it moved to preventive to a certain extent. Now moving to population health. We speak about COVID-19, where large scale vaccination was carried. That was one of the population health mechanisms that we did. What Dr. Sanjay showed here, that almost 70 million Indians are diabetic, right? Of the total population of 1.42 billion. 74 now. And while we speak, I mean, one of the strengths we as a country have is number of people, the economy of scale, which is a good thing, which is also could be a bad thing. And with last 4 seconds that I spoke about, we would have added another 4 co-citizens. Because that's the rate in which we as a country are expanding. So the only way to manage such a large population is digital health. You cannot manage, I mean, for us who are actually closer to a hospital where the nearest hospital could be 500 meters, 1 kilometer, 3 kilometers, large populations still don't have access to medical health. And the only way to do it is a digital health. There's absolutely no other way. COVID-19, actually, it taught us that. Whether we speak about Arogya Setu app, whether we speak about the vaccination mechanism, whether we speak about telemedicine. Telemedicine, when I used to study, I used to do projects on telemedicine. That now telemedicine is coming in a big way, it's coming in a big way. And last 30 years, it has been coming in a big way. And only time it peaked was when COVID-19 happened. We all actually used it. And now, last 1.5 years, let's ask all of us, how many of us have actually used a video consultation platform? We have not. Because that's what our behavior as a country, as a person is. So, but teleconsultation is just one mechanism. One of the things that digital health will solve for non-communicable disease is economy of scale, accessibility, sustainability, and costs. And I don't see any other way that you can solve this problem except by usage of technology. You can augment, artificial intelligence or augmented intelligence, you can use all these platforms or digital setup or digital paraphernalia to only augment the digital health platforms. We are still nascent in actually capturing the healthcare data, which is sort of unfortunate. All the medical journals that you find in the hospitals are actually from case studies from US or UK, because they're capturing the data, and that's the reason they're able to do the research. In India, we are still at this stage, we are still capturing the data. Whether we talk about EMR and whether we talk about EHR, unless until you have the data, what artificial intelligence algorithm that how do you train the system if you don't have adequate data? And that also will start from digital health platform itself. So that's what my thoughts are.
Great, Mr. Sujit. So, yeah, to just back up your things, like I was just going through one World Economic Forum report where it was saying that 75% of the deaths today are happening due to these non-communicable diseases. And still, as of today, 4.5 billion people are not getting the proper treatment. And by 2030, there will be a shortage of around 10 million healthcare workers. So, yeah, definitely digital health is the only solution that we can see as of today. Okay, so coming back to Dr. Sabine. So earlier I have asked the general question about the unmet needs and the problem worth solving. So just to be just to be more precise, I want to ask you like what you see like as a health tech economic welfare systems can help in they promise the how they promise in preventing the NCDs among diverse populations, and how particularly in AI and ML can help in management policies.
Not exactly countering, but let me digress just a little bit. So first of all, I see a mix of students. I think there are a couple of professors in the mix as well. Tell me one thing, what all entails digital health? Like what all? And I really want you guys to answer. You guys have heard about teleconsultation, some digital solutions. Tell me a bit more. What do you guys think? Because we have been talking about digital health quite a bit, please.
So I think for me personally, and I think also Saurabh, one of the things that we have quietly impacted is diabetes. So I'm wearing a sensor.
The Aura ring.
About sleep.
Yeah.
I have a CGM.
Yeah.
I can know about my sugar. So I think the first part to me for getting accurately on digital is diagnosis.
Okay. No, I was, what I wanted more was to understand. Say, for example, you said continuous glucose monitoring is one thing. You also have, I think, a ring. Yeah, a sleep monitoring. Along with that, so you have continuous monitoring systems. That's one part of it. What else?
When I get insights, for example, if I'm sitting the whole day,
Mm-hmm.
I can know precisely when my sugar is going low or high. And
No, so all of that is part of continuous monitoring systems. That is one. What else is digital health?
I think for me, this part of care is more about behavior change.
I agree. That's one thing when we talk about digital health. What I'm trying to engage with is what else is digital health? Please go ahead.
Last mile delivery. That's one thing that has happened in a lot of other industries like finance, FMCG, etc. It's starting to happen in India. It happened very well in Brazil. I don't remember the name of the startup. But what they came up with was trained doctors in the cities were in connection with rural doctors or even like ASHA workers here. And that enabled them to actually help them diagnose diseases better. So last mile delivery could be one of the most important outcomes of digital health.
Agreed. As an outcome, I completely agree with you. As a technology, perhaps, a mix of teleconsultation and POC devices at the end is
Yeah, the
something
devices are
that's
instrumental.
extremely important. Yes, so that also is digital health. What else is digital health? Please go ahead.
Yeah, it's working.
Fine. Like getting the health profile of an individual or a community in the computerized system.
So digital twin technology is what you're talking about. Agreed, that's digital health as well.
Yes.
What else?
Have you seen global treatment overall, like rural हो, urban हो, we are getting the same?
नहीं सही बात है
Yeah.
किसी कोई भी है अगर रूरल है अर्बन है उनको सेम ट्रीटमेंट मिलनी चाहिए
चल रहा है like in COVID, due to possibility of the digital health and telecommunication or telemedicine, we were able to know कि कैसे उसे manage करना है from a very basic level और पूरी हर जगह in every country it was followed like same pattern follow हुआ था because of the researches which were globally we were getting the results हमें पता चला कि
That is true.
this in any country, we can follow that in our country also, and that is possible because of
So simple thing, you're right कि teleconsultation and easy transformation of information
Yeah.
जो digital journals थी, जो easy IP availability था, वो भी digital health है, ठीक है? अब the reason why we did this exercise is because इसके अलावा भी there's a lot of things that entail digital health, and उसका reason क्या है? So what we are trying to do when we are trying to do digital health, what Sir is doing in terms of HMIS, in building back-end tech ecosystems that can enable all that we spoke about right now, also is digital health. So the reason why we are talking about this right now is because it's not just about what the customer or the consumer, in this case the patient, sees. Here we need to look at building the entire ecosystem which removes the need of care. ठीक है? या at least reduces the need of care. So what is the goal of healthcare? कि आपको उसकी ज़रूरत कम पड़े, right? That should be the goal of healthcare. And to be really honest, financially अगर हम देखें, which are the entities that really benefit from you staying healthy or getting healthy? एक आंसर है इसका. Exactly, insurance. So one of the key outcomes of that is also insurance. And I have not heard any of you talk about InsurTech here. So that is a very booming thing which is also digital health. Now there are shortcomings. Even in digital health there are shortcomings. For example, teleconsultation has a massive shortcoming. ठीक है? एक बहुत बड़ा bottleneck है. Please, you guys have addressed teleconsultation again and again in different applications. So tell me, what is the bottleneck in teleconsultation?
Not possible. There are certain things that you can see when the person is in front of you. That is the main
That
bottleneck
is
that
true, but now we have more and more. Resources, again, a problem, but can be met, eventually can be met. Your problem statement is also a problem, but we are developing more and more POC devices that can solve that going forward. Of course, not all of it, but many of it, and that's the whole idea, right? The mass scale up is the idea. One of the problems, one of the biggest problems in teleconsultation as a solution is the bottleneck is resource of time. We talk about teleconsultation as if doctors, there are, just because we went tele, so the number of doctors is infinite, or the amount of time that they have is infinite. That's again not true. It's a limited resource. Both the number of healthcare workers as well as the amount of time that they can allot to teleconsultation as a solution. Both of them are a limited resource. So when we look at these problems from a triaging perspective, how much of it can we use? We talk about the fact that we have, say, just 40,000 radiologists across the country, which is why we need more teleconsultation in that. But the radiologists are still 40,000, right? The number of hours that they have, they might be able to increase their outcome by, say, 15%, 20% max, but not more than that. That is where we look at AI-based solutions coming in, and one of the biggest solutions that digital technology is giving us is early diagnosis. Why early diagnosis? Early diagnosis reduces burden of care not just for you but for the entire system. So because we were talking about diabetes earlier, diabetes diagnosed early has far lesser complications than diabetes diagnosed a little later, from kidney function issues, from CKD, all the way till diabetic retinopathy. There are so many issues that will be caused just by diabetes. And the problems with their drugs cause are even further more problematic. So we are not even, so it just spirals to upwards of care. So we need to reduce the need of care. And that is what managing NCD is all about, and that is what digital technology is helping us do. We are not trying to shift the onus of care onto the patient, but the idea is to integrate all of these solutions together and understand the bottleneck in resources. So one of the great things that has happened is AI-based radiological solutions. They are not perfect, they are pretty good, they are very, very good. They're not yet perfect. They don't, still don't analyze, unfortunately, USGs and a couple of other problems. But they're pretty amazing right now as is. And they are effectively solving the problem of limited amount of time. So these are the kind of problem statements that need to be very specifically identified from an ecosystem perspective and then solved. And that is what digital health, I think, is all about when it comes to NCDs.
Thank you, Dr. Sabine. So yeah, it was good to see digital health from different perspectives and from different verticals, and to understand that that is not just putting few things, it's like holistic perspective. So I think we can now open the floor for the audience, and let's take the questions from the audience. Want to comment something?
I just want to add a couple of things what ma'am you said about last mile connectivity. And we should learn. We should learn from all the various verticals. Let's look at digital payments. Digital payments have actually reached the last mile. In the remote villages, healthcare also has to adapt itself to reach it at that. How can it do it? I mean, there is no panacea. It has to be worked out for a different, there are so many problems. We have to address each of those, and it can be resolved with those of things. So just to give you a perspective, I'm a member of NASSCOM Deep Tech. I'm also a member of ABTM of various provider groups. So technology and healthcare. Dr. Sabina also spoke about insurance technology. There are a lot of problems that can actually is waiting to be solved using technology for all of these. I mean, the other perspective is in the entire healthcare ecosystem, patient is actually in the middle. Providers, I'll park it for now. Two key stakeholders, one is insurance on one side, the other is pharmaceutical companies on the other side. Insurance does not want you to fall sick because it's a cost to them. Pharmacy company want you to fall sick. It's a fact. Same pharmaceutical companies have got insurances. Sorry? So, and there are a lot of theories that who created, well, let's not go there. Whether it was self-created pandemic or what. But the fact remains, and even those numbers of 74 million diabetic, there is a theory also which says that, I mean, the association of, American Association of Diabetics, they have said that HbA1c number, which actually tells you whether you're diabetic or pre-diabetic, that number itself is false. That was also driven by pharmaceutical company to be increased from, bring down from 7 to 6. So let's leave those things aside for time being. The resolution, or at least the start of resolution of the non-communicable disease is not medication, but education. What Sachin also spoke about, continuous glucose monitoring, it only gives you an insight. Means you have more information. Means it's an education. Education to the person who is actually in the rural village in UP or MP, if we can educate them, and it could be, and the same is spoken about cancer. There is no cure to cancer. But if detected in the early stages, there can still be a cure. And how can you detect? Is education. If you tell them if these are the symptoms, you need to go and consult. There has to be entire infrastructure to support them so that they can avail those services. Mental health. Now we sitting in the capital of the country and in such an institute speaking about mental health. I mean, we can never understand what mental health challenges are till the time we don't go to the grassroots. And that can only happen through technology, and not first capturing information, also disseminating information, which is what education would be, what I would say. Dr. Sanjay.
So I'll just add on to what Dr. Surjeet and Sabine said. So he said telemedicine has been it'll be a big boom in 15 years before, and now also it is presumed to be a big boom. the issue is we haven't been able to address the core problem. I've been mentoring startups at IIM Bangalore, healthcare startups, which has been coming in. They say, okay, as she mentioned that there are no doctors and you are asking them to do a teleconsultation. And when the technology, sad to say, there has been enough technologies, the technology hasn't been there yet to provide a seamless teleconsultations. How many of you, we have been sitting here, if the same was happening through a virtual conference, okay, how many would have faced the Zoom glitches? Or, I cannot hear this, I cannot do that, I cannot see this. Those glitches will detract the doctors from providing teleconsultations. It extends the time. When we are looking at if I am seeing a patient, or if a doctor is seeing a patient, he spends about 10 minutes per patient to see, diagnose, write a prescription, and say bye. But the same thing in a teleconsultation happens over 20 minutes. The patient will say, I cannot hear you. Can you be a bit louder? The doctor will say, I cannot see that. Can the camera be moved this way, moved that way, and all those things. So those are the glitches that frustrate us in providing teleconsults. COVID was an exception where we had to do it. But again, as you said, nobody goes through a video consult in the last 1 year again because we don't like it. And we have enough patients already walking in. Okay. So that's one. The core areas of these things hasn't been resolved yet. And as rightly said, AI is something that would surely help in filtering these and sending what is only appropriate to an appropriate doctor and not sending even a gastritis problem to a cardiologist. That is what is happening today. There is no filtering of the cases, and where the digital interventions can help there.
Thanks for that. Have any of you guys heard of something called the Watson program? I'm sure some of you might have. Thank you. So that was, they had an entire health chapter for it. IBM did a lot of work on it. And I think almost $1 billion was spent on it, trying to develop something called autonomous AI. What is autonomous AI diagnosis? You all have been talking about AI since yesterday. Come on, give me an answer, please. Someone?
Independently diagnosing various diseases based on different patterns. So what they're doing is for each specialty, they have data models developed.
That is what they are doing now with Watson X. That is not what autonomous diagnosis was about. So essentially what is autonomous diagnosis is someone who can replicate a general physician, like an AI that can do what a general physician does. Not specialized diagnosis each and every use case, or not do narrow level diagnosis, but do a broad spectrum analysis and narrow down into filtered specialties. Right? Now, this program failed in a very fantastic fashion. The reason is that one of the problems, and coming back to the overall idea of this conference, which was clinical validation, is that after almost 700 million set of clinical records, IBM figured that the outcome of it had an accuracy in terms of validity to just the tune of 37 percentile. Which is nothing, which is not clinically valid, which is not even close to clinically valid, right? You really should not put something that dangerous out there. And they had to then eventually close it all down. It was a deep learning model that they had started with. And as you guys know, because I'm sure you guys know more about tech, because I'm a physician, so I don't know as much. But the amount of data that you need to shift the percentile in decision making is massive. So, at the end of the day, again, coming back to clinical validity, is that we talk a lot about two things. Solutions in terms of AI, solutions in terms of digital health, solutions in terms of diagnosis, and POC devices. But all of it need a hard approach towards clinical validity, right? And unfortunately, we don't even have regulatory ecosystems that are that mature to force us to do that. I mean, CDSCO guidelines came around 3 years ago for medical devices, and honestly, they are a little bit of a joke. So we really need to push hard so that regulations may follow, but we need to be clinically validated across all chapters of digital health, especially when we are looking at something very critical, which is NCDs, because they have long-term applications, long-term outcomes. If a population has low NCDs, that means even if an infectious disease is running rampant, the morbidity is going to be less, the mortality is going to be less. So in case if we were a healthy population, our mortality and morbidity during the second wave would have been less. That is a basic understanding, right? It's like basic logic, that you would have been healthy throughout. So that is one thing that we really need to look into, that the solutions that we are building, first of all, are we solving the right problem? Are we building it at an ecosystem level which is comprehensive to other things that's happening and not just making the same thing over and over again just with a different label? And third, because resources are limited across the world, and we have even more so limitations in terms of resources, both financial and physical. So why not spend it to solve the right problem? So identifying the problem is important, and then after that, look at whether the solution that we have designed, is it valid enough for the outcomes to make sense. So I think taking that entire journey, and I think you spoke about the entire journey, right, in terms of validation, that is going to be extremely important going forward, and from a perspective as well, which I think would be the only thing that we can give you. Rest all you can learn from Google anyway. So.
Okay, yeah, thank you. So like we have last 5 minutes around. So yeah, we can take some questions from the audience.
I can just, yeah. So Dr. Sabine, I think point well taken about what's an IBM. I think the challenge there was perhaps they overstated their AI. With large language models which came later, I'm also a clinician. I am very skeptical of AI, even though a developer of AI. But when tall claims like what IBM did come, I'm very skeptical. So I completely resonate with the sentiment. But at the same time, I think as clinicians, we have also perhaps not done our job fully well. We have not actually supported a lot of AI development that we need to support by being technology averse.
For sure.
So I think, and to you, as my question is, that's changing perhaps, but how do you make that happen in a country like ours?
Education. I mean, you guys are doing it here, but education starting at the level of medical colleges, if we do have tech built in, finance built in. I mean, most doctors don't know how to process a claim, how to record data sets. And they, even if they don't have time, they can actually train resources to do it if they know how to do it, to build with. And it's about habit formation, right? I mean, eventually, if the need arises, you build a habit, but it will take a generation to make that shift, I think. At least half of it, for sure. And secondly, I think it's also a game of data. The amount of information that we are capturing, how do we collate it? What are the insights that we are really drawing out of it? So a lot of work needs to be done in gathering the right information, not duplicating it over and over and over again, just because, right? And I think a lot of work from a system building approach is happening in those areas. So it will take its time, but I think it will happen eventually. So that, and one more thing, and this was a very, very interesting anecdote you guys should know. So I was recently reading a paper about CV training on ML models, right? So this was actually an ML that was trying to recognize cancer notes in dermatological cases. And they actually trained it on the entire Google's image, this thing. And this was one of their retina applications. So what happened is that after a certain point, they started seeing images of dresses and other things instead of this thing. Do you know why this happened? It was a very interesting use case. So I'm sure you might have read it. It was in the news as well quite recently. They started seeing, kapde ke and all cut pieces around instead of tumors. Why did the AI start recognizing kapde ke cut pieces? Do you?
Because it's been trained on such a large set of images that it is, the AI basically builds patterns out of things it sees and creates associations. So when you train it on non-specialized data, which is a large set of data, which can go from clothes to accessories to whatever, because Google Vision has this problem when you try to train it like this. So I'm just guessing, because I've not read your particular news. So when you train it on something, because it has already trained on so much of data, it's able to associate and bring those
so
things.
it is on the same this thing, but it's much simpler than that. So what happens is that when we take medical images, we put a ruler in front of the tumor.
Ruler.
Yeah, a ruler to measure it. And almost all images had rulers. And they actually started recognizing that any image with a ruler is actually a cancer tumor. So that's the black box problem all over again, right? You don't know what is actually being built. That is the problem of the black box problem, which is a regulatory problem that we are facing in terms of regulating something that even the makers don't know how the images, how the data is being processed. So I think that is, again, talking about the whole ecosystem solution. We need to look at a problem statement as well as a solution from multiple angles before we put it out in the market. So I think it was because the anecdote was so simple. I mean, looking at it, because they started looking at rulers, and then every image that had a ruler, they started categorizing each of that image as a tumor. It was so funny, but very problematic, but very funny as well. So,
Yeah, so Mr. Surjeet, like you want to say something on this?
Yeah. I had a question and a point to make about what you discussed itself. See, I come from not the healthcare background, I come from a technology background. So we work on AI. And it's very important to understand that I don't think there should be aversion to tech, but I also understand that there are fears of how it could possibly go wrong. And us being developers, we've seen it firsthand. So
completely
we
agreed.
do.
We are a mess. Physicians are bad at adoption.
That's where we collaborate, right? Health tech, right? So what we've seen is something, exactly what I've been trying to say this whole time, is you have to have specialized models. Because AI's differentiation mechanism is not as evolved as humans. You can't have a GP. Like for example, if you get ChatGPT or Bard to code, their code and the library version put off. You'll never see a human doing that. So I've pushed my to do it a bit, and they're like, they're stupid. We can't get them to do it anymore. They're getting better. So what we are doing internally now is, based on the languages and versions we use, we train AI only on and for practitioners, you know, when you talked about last mile delivery and the lack of resources, AI stepping in, one reason why it's been so helpful in radiology is because specialization. So if a normal doctor, you know, you can't eliminate the doctor, have the doctor, but then, you know, bolster their capabilities.
CDSS support system.
Exactly, assist AI, so that they don't have to do the grunt work.
Exactly.
They can do the intelligent work which humans are capable of, and AI currently is not.
Yeah, so data processing and building those out as a basic segregation model is the best way to go about. Yeah, agreed. Completely.
So just to add, that's what we said when we developed the AI for the wound care. We said this is for the health workers, not for the patients. So when we started taking images, as she rightly said, if the patient was wearing a red sari and we take the image along with the sari, that was also recognized as a wound. Okay, so
That's what we call as noise.
yeah. So that we'll have to, so we said this is for the physicians so that we do the intelligent work rather than the basic work. Completely agree with you.
So yeah, in the interest of time, I think you can always like interact with the panelists outside of the lunch. So we have to stop the flow of the event just for maybe lunch. So yeah, I think that was wonderful, and thanks for the organizers, Dr. VK Singh, Sachin, and yeah, thank you.
As we draw to close this session, I would like to thank all our panelists for this insightful session, being so engaging and informative. I would now request Dr. Saurabh Gupta to present our panelists with a token of appreciation. We start with Dr. Sabine Kapasi, renowned expert health policy and governance strategy. Please put your hands together for our panelists. Next, we have Dr. Sanjay Sharma, co-founder, FootSecure, Yostra Labs. Please put your hands together for him. Next, Dr. Surjeet Thakur, founder and CEO, TrioTree Technologies. Please put your hands together for him. I request Professor Lavanya, Director and Principal, Nightingale Institute of Nursing, Noida, to please felicitate Dr. Saurabh Gupta. Thank you so much, ma'am. Thank you so much, all our esteemed panelists. You can take your seats downstairs, and we'll start with our next session.